Hello, everyone, and thank you for joining us today. I am Chris Salliers, the Education and Services Director of the National Organization of State Offices of Rural Health, and I have the pleasure of welcoming you today to our webinar, The Intersection of Workforce Incentive Programs and Telehealth Policy. In today's session, we will describe National Health Service Corps policies related to telehealth and interstate licensure laws and compacts. We'll summarize National Health Service Corps policies related to acceptable telehealth technologies, and we'll distinguish challenges and opportunities for telehealth in addressing rural workforce needs. Before we begin, I would like to recognize the fact that there was a lot of work that went into pulling this webinar together. This topic first came about through the results of a primary care office technical assistance needs assessment as something that PCOs across the country were interested in. Those results went through the PCO National Committee, who identified a webinar topic and really helped to shape the direction of today's presentation's content. Our presenters today had the extremely arduous task of sifting through all the new regulations and policies to bring us the most current and relevant information. And most importantly, all of this work is carried out through the thoughtful partnership and support of the Association of State and Territorial Health Officials, or ASTO, particularly for this under their cooperative agreement with HRSA. So if you filled out the PCO TA Needs Assessment Survey, if you serve on the PCO National Committee, or one of our fantastic presenters today, or a member of the ASTO team, we really want to thank you for all your support in making today's presentation a reality. A couple of quick housekeeping items before we get started. First, we wanted to let you know that all phone lines are muted during the presentation. If you have questions, please enter them in the chat box on the right. We have this little diagram to show because sometimes it does get a little bit confusing, but the chat function's on the right-hand side. When you are wanting to communicate, don't just do host. Make sure you're doing it to all panelists, and then that way one of us will be able to respond to you in a timely manner. That really helps. And then if you would like to save the slides, you click on what looks like a marker in the top left. That sidebar will pop up, and the icon that looks like a floppy disk allows you to save the slides. At the end of the webinar, or at the conclusion of the webinar, we will take questions as time allows through the chat function. After the webinar is ended, a survey will pop up. Please take just a couple of minutes to answer those questions. And finally, the presentation and slides will be available on the ASTO website, along with their many other great resources for primary care offices and those who support their work. So with that, I would like to introduce today's presenters. Keisha Smith is the Executive Director of the Virginia Health Workforce Development Authority and serves as the Program Director for the Virginia Statewide Area Health Education Centers, or AHEC program. In her capacity as Executive Director, Ms. Smith is responsible for leading statewide health workforce development efforts. Ms. Smith is a public administrator with over 15 years leadership experience in various corporations and public agencies. Throughout her career as an administrator, she has earned a stellar reputation for her keen intellect, integrity, and professional expertise. In her previous role with the City of Richmond in Virginia, she was responsible for research and policy development to tackle many of the critical issues facing health and human services. She led several mayoral initiatives, including the Mayor's Healthy Richmond campaign and Blue Ribbon Commission on Health Policy, and served as the director of the Richmond City Community Schools Initiative. Previous to her employment with the City of Richmond, Ms. Smith worked for the Virginia Department of Health as the Health Workforce Program Manager in the Office of Minority Health and Health Equity. In that role, she provided oversight and coordination for health workforce recruitment and retention initiatives and incentive programs. Also joining us today is Dr. Kathy Wibberly. Kathy is Director of the Mid-Atlantic Telehealth Resource Center, The Telehealth Resource Centers are federally funded to assist with telehealth program development and sustainability in order to increase access to quality care for rural and other underserved populations. Kathy is also Director of Research at the University of Virginia Center for Telehealth, Assistant Professor of Public Health Sciences at the UVA School of Medicine, faculty at the Healthy Appalachia Institute, and adjunct faculty for the L. Douglas Wilder School of Government and Public Affairs at VCU. Prior to her position with Matrix, Kathy was Director of the State Office of Rural Health and Primary Care Office within the Virginia Department of Health Office of Health Equity. Kathy's public service career reflects over 25 years of experience in public health, public policy, program development, program evaluation, and strategic planning. So with that, I would like, please join me as we welcome Keisha Smith to take on.
Thank you so much. Can you hear me?
Yep.
Okay. I'm not able to, it's not allowing me to advance the slide.
Where it says intersection of workforce at the top, that switch between intro slide to your slide.
Yes. Okay. Thank you.
Mm-hmm.
So my objective today is to provide a little insight on the recent NHSC policy changes related to telehealth. So here I'll begin with the vision and mission of HRSA's Bureau of Health Workforce. So I'm sure all of you are familiar with the vision, which is to make a positive and sustained impact on health care delivery for underserved communities. And the mission is ultimately to improve the health of these communities by improving the health workforce and connecting qualified professionals to communities in need. So on the right, there's a little infographic of some of their program categories, including the scholarships and loan repayment programs, health professions training, and GME. At the recent National AHEC conference, Captain Jacqueline Rodriguez highlighted the Bureau's success in promoting modern care by advancing changes in health professions training that are responsive to the evolving needs of the healthcare system, by encouraging the use of telehealth technologies to improve access in underserved communities, and by removing telehealth barriers for NHSC. Those were some of the activities that were mentioned. So, for many in the field, telehealth has been viewed as a critical resource for increasing access to care and ultimately moving the dial for vulnerable populations. And stakeholders, including funders, such as HRSA, began making changes to allow for the utilization of telehealth. And in the recent FY 2018 guidance that was issued by NHSC, you noted some critical changes. And so all the provisions under the Telehealth Policy section are not listed on this slide. However, the slide does reflect some of the major changes. Okay, so one of the biggest limitations was the hours. So in prior guidance, the limitation was, no more than 8 hours for full-time telehealth practitioners could be in telehealth encounters. So, of course, the new threshold, it's been lifted and under the new guidance, and it allows for up to 100%. So that, a lot of folks, I know me included, looked at that guidance and kind of glazed over that, and it was like, wait a minute, where's the, the limit? What's the limit? And so the threshold has been lifted. So that's one of the, biggest changes that you noted there. All originating sites, the location of the patient and distant sites, the location of the practitioner, must be located in HRSA and must be approved. So that's the same. But NHSC clinicians must be available to provide in-person care, and that is, at the discretion of the site, to define that and to determine the capability of the provider to be physically available. But that is one of the provisions. Another change, I believe, is that self-employed clinicians are not eligible for service credit for telehealth services. So if the clinician, is a solo practitioner, then self-employed clinicians are not eligible for this new under this new policy. Telehealth services are defined, of course, as two-way, real-time interactive audio and video communications. That is outlined in the previous guidance as well as this guidance, the most recent guidance. So why were the changes made? What's driving the efforts? So I mentioned, that stakeholders have, long understood the importance of telehealth, and it seems as though HRSA is continuing their effort to hear from and learn from the grantees and other stakeholders. So, of course, their ultimate goal is to reach those in need. Right, so they've listened, they've heard from partners such as the federally qualified health centers regarding issues with providers not being able to go to all the sites, and they've aligned internal policies to be more expansive. So what you've seen in the recent guidance is the decision to kind of set the framework for states to kind of adapt telehealth policies as it relates to NHSC participants and grow with that. So even if the states are not reimbursing, that's one of the challenges that I'm sure Kathy will talk about later, but as that comes down the pike and those approvals are made and the legislation is changed, the NHSC guidance will be able to, it's already accommodating. And so that was, I think, one of the goals when they considered the research and the data as well as what the stakeholders were saying about the needs in their communities. So Chris mentioned I am the state program director for the Virginia AHEC program, so I cannot wrap up without putting a plug in for AHECs, right? At the national conference that was held actually last week, we learned that supplemental funding is going to be provided for AHECs AHEC-related training activities supporting opioid use disorder, diagnosis, prevention, and treatment through trainings on telemental health services. AHECs at that conference asked the HRSA folks if, some of our participants could be given preference or, if there was a way that AHEC participants, particularly in our AHEC Scholars Program, could receive credits for when they do apply for NHSC programs such as the loan repayment program, then that is something that may be considered in the future. So connect with your local programs to discuss the AHEC Scholars Program, but also other potential ways to collaborate around telehealth. Another model that's been adding and will continue to add to the body of evidence regarding the impact on telehealth is the HRSA-funded Telehealth Resource Center program, which you will hear more about from Kathy. So that's what we came up with when we did the research, and I think that's all that I have to share. I appreciate your time. Thank you so much, Kathy.
Great. If you'll move the ball over to me, and I will work on the slides. All right, so as you heard from Keisha, there are all sorts of reasons for telehealth, and so really quickly, obviously this is the one thing that the NHSC programs want to address, the filling the void piece about access to care and access to clinicians. But that really isn't all, and I think one of the things we need to really be careful about is what NHSC will fund versus other opportunities for telehealth for clinicians, and being able to introduce that and help people and support that. So another major issue with telehealth is improving health outcomes, and of course we all want that. It's not just about accessing providers, but it's about really improving the health of communities, and particularly those in underserved areas. And so telehealth is used for a number of things, from patient education to chronic disease management to access to preventive screening, access to interprofessional care, clinician continuing education. So I think we need to separate out what you get credit for versus what you can do with telehealth if you have that technology available to you, and we need to help clinicians really try to understand that. Now, obviously, cost is always a big picture issue, and so there are all sorts of reasons for decreasing costs and how telehealth could play a role in that. And so, recruitment and retention is something that we all deal with. And so, obviously, if we don't have to continue to recruit and try to retain providers in underserved areas, that is going to be a cost savings for any community as well as any healthcare facility. And so one way that telehealth really helps to do this is to decrease isolation, to give people a real sense that they are part of a care team. And so I think as part of this whole NHSC and recruitment and retention effort, we really need to think about how do we market this? How do we build telehealth into these programs and make that a marketing tool and a marketing message? So what I want to do is just wrap up by addressing some of the challenges that you're going to face as you start entering more and more into this telehealth realm, because the challenges are real, but they're not they're not barriers that are hard to overcome. And so the one thing that people always talk about is reimbursement, and yes, it is a challenge. And so I'm going to give the kind of big picture framework around reimbursement and then talk specifically about Medicare, Medicaid, and just private payers. But reimbursement, the reason reimbursement is such a challenge for telehealth is because it varies by a number of factors. It varies by payer. So one of the key questions, when people say, can I get reimbursed, you really have to ask who is the payer. Obviously, self-pay is not a problem. For public, there's differences between Medicare programs and Medicaid programs, and there are also differences in commercial state licensed programs versus self-insured employer plan programs. And so those are, always ask who is the payer that you're asking about. Telehealth reimbursement also varies by what mode of telehealth is being used, and there are 4 primary modes of telehealth. So one is synchronous live video, and this is the only mode recognized by NHSC for service credit, but that doesn't mean that you can't do the other modes. It just means that NHSC will only recognize that time spent using synchronous live video. But there's also, and synchronous live video is what most people understand as traditional telemedicine. The clinician is connecting by live video to the patient using peripheral devices to get patient data, and the interaction is, between the patient and the clinician, and sometimes between the clinician and the clinician or a care team. Asynchronous or store and forward is what is typically known as what you would see as, let's say, an X-ray technician who sends an image to a radiologist. If you end up in an emergency room after hours, chances are pretty good at about 90% of your X-rays are going to be read by a radiologist on the other side of the country or the other side of the world where they are awake and they are working, and you don't have to pay someone overtime to cover 24/7. But basically, they're reading the images, reading the patient data, teledermatology or diabetic retinopathy, the eye screening. Those are all things that can be done by Stoller and Thorud. But NHSC right now does not recognize this, but some payers will. So there's one of those areas where we need to kind of differentiate. Remote monitoring is another mode where for chronic disease management and for readmission penalty management, patients can go home with Bluetooth devices like blood pressure cuffs, weight scales, pulse ox, glucometers, and those readings are sent daily to generally a nurse-managed call center, and they monitor that patient's conditions, and if their readings go outside of what the normal range is for that particular patient, the call center gets a red alert to contact that patient and find out what's going on. It has been used very, very successfully in chronic disease management. A lot of it is because it engages the patient in their own care, and it gives them the education they need at the time that they most need it. So, when your blood pressure is up and you get a call saying, Mrs. Smith, something is going on, it could be something as simple as, oh, I forgot to take my medication today, or it could be more complex, like, oh, I just went out to eat, and to celebrate a birthday and went to a big buffet and had all this, salt. But it's a time for really being able to communicate with patients and improve their health care by figuring out what's going on at the point when something is actually going on. And what we will see more and more of is mobile health, and that could include live video to the home, or it could include simple things like text messaging messages. But those are all aspects of telehealth, and some of those things are reimbursable, some of those things are not, and it really depends on the payer source. So the other question you ask when you figure out if telehealth is reimbursed is, where is the patient? So that's called the originating site. NHSC only will count towards service credit if the patient is located in a healthcare facility that's approved by NHSC and located in a HRSA. But that is not necessarily the case for the payers. So that's another area where we really need to kind of pay attention to, who's going to pay for what. So you could have a patient either at a healthcare facility or at a non-healthcare facility. A non-healthcare location could be, let's say, if you're providing care to a patient directly at their home, or it could be a kiosk, or it could be at a school that's not a clinic, but just, in a classroom setting, or it could be in a workplace. But those are non-healthcare locations where telehealth could potentially be reimbursed, but not necessarily. And then you also have to ask about rural versus urban for the Medicare piece. And so, again, where the patient is located does play a role in whether something is reimbursable. Another thing to ask is who is getting the consult. And so right now, there are all sorts of models for telehealth. There is the, to the far left on your screen, telemedicine consult clinician to patient, and it could be asynchronous or synchronous. But there is also an e-consult model, which is clinician to clinician. And right now, there are very few reimbursement sources for that, but that's in the works in a number of venues. There's also Project Echo, which is clinician to clinician synchronous, so live video, where primary care providers are connecting to specialists to really enhance their capacity to keep patients in the primary care setting where that is feasible and allowable, and obviously increase the capacity for primary care providers to actually maintain those patients and only referring out those that really need to be referred out. And that has all sorts of impact on workforce capacity. So another thing to ask in terms of whether telehealth can be reimbursed is what type of provider. So almost all payers will reimburse if it's a doctor or a nurse practitioner. But it will then vary based on other health professions. So a diabetes educator may or may not be reimbursed. A speech therapist may or may not be reimbursed. An EMT is typically not reimbursed. But those are questions that you really need to ask very carefully. And again, what type of service is being provided? So there are all sorts of restrictions on what CPT codes will be reimbursed and which ones will not. And so that's another question that you need to ask. So getting back into the more specific payer sources, Medicaid varies by state. Each state has its own policies, and each state can determine its own policies related to telehealth. So as you'll see on this little chart, 48 states and the District of Columbia reimburse for live video through Medicaid, but not necessarily for every CPT code. 21 states actually reimburse for remote patient monitoring, and one will reimburse for remote patient monitoring through the Department of Aging Services, but not for the general Medicaid population. 15 states reimburse for store and forward, which is the asynchronous telehealth, and that will be increasing probably pretty rapidly. Most states don't view email, phone, or fax as an acceptable form of service delivery for telehealth. 32 states reimburse for a transmission or facility fee, meaning wherever the patient is located, if they're connecting to another provider who's at a different location, that location where the patient is physically located can get reimbursed usually somewhere in that $20 to $30 range. A little bit of kind of the facility fee for the time that it takes for them to manage that patient who is at their facility getting the telehealth consult. Now, a thing to pay attention to is fee-for-service Medicaid is often different from Medicaid managed care. And I know many of our states have transitioned or are about to transition into Medicaid managed care in a fairly large-scale fashion. And so I know that quite a few states have huge differences in what is reimbursable in the fee-for-service Medicaid program versus what's in the Medicaid managed care contract. Most states provide these managed care agencies greater latitude for telehealth than in the fee-for-service program, but it will depend on what's in the contract. And so it's up to that managed care agency or the contractor to say, this is what we want to reimburse for, this is the scope of what we will use in terms of telehealth. And oftentimes you really need to educate them on the value of telehealth for them to put that into their state contracts. Now, other states put requirements in their managed care contracts, so again, it really varies by state. For those of you who really want to know what's going on in their particular state, the National Telehealth Resources Policy Center, which is at cchpca.org, has a database as well as an updated, every 6-month updated law and policy kind of guidebook. It goes through every state. Their database is fabulous. So if you can go into the database, select what state, select what type of law or regulation or Medicaid program policy that you want, and it will pull up the current regs. It'll take you to the link to the actual source document where that's available. It will also give you pending regulations, things that have been proposed, things that are enacted but like delayed. So that's a great resource for you to find out what the policies are in your particular state. In terms of commercial plans, some states have what's called parity laws and others do not. Right now, 36 states and the District of Columbia have active parity laws. Parity legislation or parity laws means that for commercial plans, they are required or they cannot say we're not covering for telehealth. So if it's a covered service in an in-person consult, they are technically required to also cover that service if delivered by telemedicine. Some will have restrictions on we need to have pre-approval or there are certain things that we don't feel like are suitable for telehealth, so we might not give approval for those things. But in general, these are, if they have parity legislation, they are required to reimburse. Now, another piece to be careful of is some states have parity of coverage as well as parity of reimbursement. Other states' language have just parity of coverage, meaning it's covered, but the commercial payer actually has the prerogative to say we'll pay less for telehealth or we'll pay a different fee for telehealth than in person. And so that is something that we need to be a little bit mindful of. Now, those states that have parity laws, those typically apply to commercial plans, but they don't necessarily apply to self-insured plans. So this is why this whole landscape and reimbursement gets very complicated. So those are questions that you do need to ask. So for Medicare, and this is probably the most restrictive of all, Medicare has place restrictions. So a patient has to receive services at one of these types of healthcare facilities. So provider office, hospitals, critical access hospitals, rural health clinics, FQHCs. These are most likely the facilities that your NHSC folks or people who are participating in your loan repayment programs and other workforce incentive programs are going to be in anyway. But you do need to be mindful that Medicare will only reimburse if the patient is receiving services at one of these facilities. And the facility has to be located either in a non-MSA or non-metropolitan statistical area or in a rural health professional shortage area. And so there is a tool on the datawarehouse.hrsa.gov tool and you can search for, rural telehealth eligibility analyzer. If you put those words into Google, it'll come up with this. And you basically put the address of the site where the patient would be located for telehealth services, and it will tell you if that address is eligible. Of course, it still has to be an eligible facility. Did not want to advance. I don't think the rest of the slides loaded for some reason. But just to give you a little bit of an overview of what I'm not seeing the other slides for, but let me pull them up on my end so I can make sure that you get the information. The other piece for Medicare is that there are a very limited set of providers that they will reimburse for, and so they are related to nurse practitioners, physicians. Let's see what else.
Kathy, Beth is going to try to reload. I don't know what happened and why those slides got cut off, but while Beth reloads the slides for us, where we're at this point, if there's any questions, please go ahead and put them in the chat box. We apologize for the technical difficulty on this, and Beth is going to try to get us reloaded.
No problem, and I can try to continue. So nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, clinical psychologists, clinical social workers, registered dietitians, and or nutrition professionals are pretty much the only eligible providers. And they also have a specific set of CPT or HCPCS codes that they will reimburse for, and those are very specifically dictated. And they're announced each year as part of the physician's fee schedule. And so in billing for telehealth, billing Medicare, they want you to use the O2 place of service code if a service is being provided by telehealth, and this would be synchronous only. If store and forward is only allowed right now by Medicare if you are in a demonstration program, and that would be Alaska and Hawaii only. There is a process that CMS has for you to request that they consider a different CPT code or HCPCS code for telehealth, and there is a website that will give you information on how to submit a request for consideration for the upcoming physician fee schedule. The physician fee schedule is generally published November 1st of each year, and that adds all the new services that will be reimbursed. One of the things that we know that they just released through the Federal Register this past week are proposed changes for 2019 for Medicare reimbursement. And there's some really interesting things in there right now, and for the most part, unless they get a ton of opposition to these changes, will make that cut and become part of the physician fee schedule when it gets announced in November. But proposed changes for 2019 include something called virtual check-ins. So they've added a new code to pay providers to do virtual check-ins with established patients only. So it rules out the kind of teledoc, acute care, call this number or connect to this video for a visit. But if you have an established patient in your clinic, and you want to be able to do a virtual check-in to prevent them from having to come to the office or go to the emergency room by connecting to them at home, Medicare now is proposing a code that would allow you to do that. They have also added store and forward as a code for remote evaluation with pre-recorded data, and that's huge because it will, for the first time, take the store and forward piece outside of just a demonstration project to anywhere. And one thing to really think about is that store and forward code, so the reason that Medicare has restrictions on geography is because there's a statute that basically restricts telehealth under Medicare to rural underserved areas. So Medicare as a way, and the reason for that is because of the CBO or the budget office always scoring this as if you expand it, it will bust the budget, even though, historic data has shown that telehealth does not bust anyone's budget, but they have always scored it really high. So with store and forward, as well as with remote patient monitoring, Medicare has taken those things and said, we're not defining that as telehealth. We're only defining real-time synchronous video conferencing as telehealth. And so by taking that definition out of telehealth, they are no longer, or they're able to bypass the geographic restriction area. So now if you have an underserved patient, even though they're not in a rural underserved area, they can be reimbursed for the store and forward, using the store and forward code, as well as for remote patient monitoring code. Preventive services, they've added new telehealth codes for prolonged preventive services. So I don't know specifically all that means at the moment. We're trying to get a little bit more detail on what they define as that longer term preventive services, but those are certainly things that we need to keep an eye on. So some of the exceptions in Medicare in terms of the restrictions are Medicare does offer funding for demonstration and pilot programs as well as the kind of innovation programs, and those often have exceptions so that you don't have to have the geographic restrictions if you write those into your plan. Waiver programs are one of those types of demonstration programs that has eliminated the geographic restrictions. So, for example, the dual enrollee programs. So you need to check with your state because many states have written telehealth for all recipients into it if they're a dual enrollee. Second-generation ACOs already now, as well as all ACOs beginning in 2020, will not have the restrictions on Medicare that are in the traditional program. Comprehensive care for joint replacement is now, telehealth is considered a bundled payment piece, and so that is outside of the parameters of those restrictions. Medicare Advantage programs beginning in 2020 will be exempt from some of these other restrictions. And I already mentioned that remote monitoring in the context of chronic care as of this current year bypasses the geographic restrictions because they took it out of the definition of telehealth. So with all of that said, the other big piece in terms of challenges is the interstate licensure piece. And so I'll just really quickly talk about this. So right now, the criteria for issuance and enforcement of health professional licenses is a right that's been delegated to the states. Therefore, states define their criteria. Right now, all of our states basically have the requirement that a provider has to hold a valid license in the state where the patient is physically located at the time of service. The only exception are those providers who work for the Veterans Health Administration where they have true portability and reciprocity in their license. So if you work for VHA and you can see patients anywhere in the country. But otherwise, the provider has to hold a license. So technically, it's, if I have a patient who, let's say I work in Pennsylvania, I have a patient in New Jersey, and it's a 20-minute drive, That New Jersey patient can drive over the bridge to my office, and I can see them no problem because that patient is physically located in my office, and I have a Pennsylvania license. But if I try to do a telehealth consult to the patient while that patient is sitting in New Jersey, I would be out of compliance with laws, and I would need to have a New Jersey license. So that is one of the challenges. There are a number of things underway to kind of mitigate some of those challenges. One is called the Interstate Medical Licensure Compact. The language was drafted by the Federation of State Medical Boards. It is not true reciprocity, but it's an expedited process for obtaining a physician license in a compact state. Right now, it's been enacted in 22 states and D.C. 3 additional states have proposed that legislation. Of course, it doesn't bypass the requirement. You still have to be licensed in every state where you're going to see patients, but it does make the process a little bit more expedited for clinicians. Another compact that actually has true reciprocity is the Enhanced Nurse Licensure Compact, and it's for RNs, LPNs, and licensed vocational nurses. It's been adopted by 26 states with 5 others who have proposed legislation. The National Council of State Boards of Nursing has recently also approved the creation of a new interstate compact for advanced practice nurses, so keep an eye on that one. SciPact is a psychology license compact, and it allows for telehealth and temporary in-person face-to-face practice across jurisdictional boundaries, currently enacted in 6 states with 2 additional who have proposed legislation and 5 additional licensing boards who have endorsed it. So when that 7th state enacts, it will become official, and then that compact then will go into developing kind of all the processes and procedures for that. So that is up and coming as well. And the last profession that is working on a licensure compact is physical therapy, and theirs is also true reciprocity, now enacted in 21 states with 3 who have proposed legislation. So another thing to keep an eye on. So just for those of you who are not aware, the Telehealth Resource Centers, which I am part of, we are also funded by HRSA through the Office of Rural Health Policy. And there are, let's see if I can get to that last slide. So we are divided up by 12 regions. I am the dark purple region, so we're mid-Atlantic, but every state as well as the Pacific Islands has access to a telehealth resource center. So please refer your NHSC scholars, your NHSC sites to us if they want any questions answered related to telehealth. We're happy to walk people through, help them with everything from selecting the right technology to developing protocols to where do you access training, as well as to answer the questions about reimbursement. There's also 2 national resource centers, one called TTAC, which is telehealthtechnology.org, and they are the assistance for technology assessment piece and helping people understand technologies that are out there. And then I already mentioned the National Policy Resource Center, which is really to help people understand the landscape of telehealth policies throughout the country, including Medicaid and licensure. So this is my contact information as well as Keisha's contact information, and we are happy to answer any questions.
Thank you so much, Kathy, and Keisha as well. Thank you for bearing with us while we got through whatever the technology glitch was. But it's a wonderful presentation. Are there any questions? If there are, please feel free to enter them into the chat box, and we will we'll respond to them. So, Kathy, while we wait on questions, I personally have a question about this. I wonder, will there be, so for a rural health clinic to get signed on to National Health Service Corps, there's a lot of administrative overhead there. So is there, with the expansion of all the National Health Service Corps work, Kathy or Keisha, is there additional support in any way for rural health clinics as they try to kind of go through this process, or is it really going to be leaning heavily on the primary care offices in the state? Any insights on that from your readings?
We are actually, the Telehealth Resource Centers are developing a series of webinars directed specifically at FQHCs, but most of the laws relate around, or the kind of differences in telehealth apply to RHCs as well. So I would definitely keep your eyes open to that webinar series. I didn't mention, but there is a restriction in Medicare for FQHCs and RHCs that I probably should note, that right now under the existing law, FQHCs and RHCs can't act as the distant site provider for telehealth and get reimbursed for it. So they're allowed to do it, but they won't get reimbursed for it through Medicare. So for example, if an FQHC hires a psychiatrist and that psychiatrist wants to provide telehealth services and that patient is at a different site, that FQHC can't reimburse because they're acting as the distant site provider. And that is something that there's all sorts of federal legislation trying to fix that issue. And it was historically because RHCs and FQHCs were never recognized as being able to provide specialty care. It was more, they were the site of service for primary care. And that kind of historic thinking about what FQHCs and RHCs do has created this limitation. But state Medicaid programs are not under that same restriction. And so they, as I mentioned in the previous slide, Medicaid programs have the prerogative of saying, yes, FQHCs and RHCs are eligible as distant site providers. Some states have done that, other states have not, but that is an area where you could conceivably do some educating of your state Medicaid agencies if this becomes an issue.
Thank you. That's a lot of really good information. It seems like there's a lot there, right? We had a question, not so much about the content, but about the charts and diagrams that you used in there. These slides will be made available on the ASTO website. But are those charts, especially the maps, are they available on your website, on Keisha's website, either one? Where can somebody go to find that information?
Besides from the slide, they come from the agencies that manage those particular, I'm assuming you're talking about the different compacts. So the compacts, if you Google the compact itself, the name of the compact, each of them has a specific website, and you can go to that to pull up the status of that compact and what states have enacted and or adopted.
Great, thank you. Okay, well, I'm not seeing any more questions coming in. Okay, well, with that, we want to thank you all again for joining us today, and a huge thank you to Keisha and to Kathy for this great information. And there's a lot in there, and I know that there's a lot more still yet to dissect and to figure out all the individual pieces. So be sure to reach out to your telehealth resource centers if you have other questions about this. As I mentioned earlier, there'll be a survey that you'll see. Please take a few minutes to complete that. And with that, have a great rest of your day, everyone. Thank you. Goodbye.